be hearing about health and homelessness in Alaskan Natives and the aging population. So please welcome Dr. Jordan Lewis.
Does this work all right? Okay. I'll try to talk loud. Good afternoon. I'm Jordan Lewis. My family are Ally from the native village of Naknek, which is located in southwest Alaska. This is just a picture of my family are commercial fishermen, so we fish every summer, and I go to visit when I can. So I am an assistant professor with the School of Social Work. I'm also affiliated with the Indigenous Wellness Research Institute. And all of my research I do is with Alaska Natives, whether it's healthy aging, dementia and Alzheimer's, and now looking more at health conditions of homeless Alaska Natives in urban settings such as Seattle. So that's to get this talk. I'm also the instructor on record for the Indian Health Pathways course. So I gave a lecture on some of my research with Alaska Native older adults and was asked to come talk specifically more about health conditions of American Indian and Alaska Native homeless people. And because there is such little data out there on the prevalence, the percentage, the health conditions of American Indians and Alaska Natives to begin with, there's even fewer when it comes to identifying those who are homeless. So I'll do my best to do a presentation to give you an overview of who is the aging population, what are some of their challenges, and what to expect as the population of older adults is growing rapidly. I'm not sure you've heard the statistic, but every 20 seconds someone turns 65 for the next 25 years. So you can imagine the need for people who work with older adults or have a knowledge to work with them in any capacity is really important. So I had a catchier title for this, but I just chose Homelessness and Aging, specifically American Indians and Alaska Natives. And feel free to interrupt anytime. If something doesn't make sense, you want to ask a question, raise your hand and I can definitely answer throughout the presentation. So older adults who are aging into homelessness or aging as a homeless individual have 3 to 4 times the mortality than the general population. This is due to unmet physical needs, physical health, mental health, substance use and treatment needs. And I'll talk a little bit more about it, but when you imagine someone who's 70 years old, those same health conditions exist in someone who's homeless when they're 45 or 50. So just to give you a picture about the King County area. Every year they do the one-night count. To get a general overview, outreach workers spend 24 hours or 12 hours out in the field in the middle of the night collecting data on the homeless population, specifically those who are on the streets or unsheltered. And as of December 2015, there were 10,000 people homeless in King County, and 900 of those were over age 50. And then there were 2,372 homeless single men over that age, and 836 homeless women that are single and don't have families. And then nationwide, the homeless population is growing rapidly. I guess not rapidly, but compared to what it was in the past. In 2007, it was 4.1% of the population, and as you can see, over the past 7 years, it's been growing a little bit each year, every few years, with projections to be up to 25% by 2025. So as you notice in the 2 slides back, men outnumber women in terms of the homeless population. They're 4 to 1 among the homeless older adults. And as you get older, the gap even narrows even more. So you have a lot more homeless men. We'll talk a little bit more about what that means and why there are fewer women. And men are more likely to use services. So it might be there are equal numbers of women who are homeless, they just don't access the resources as much as men do. So maybe they're not heard, they're not counted, or they're hiding somewhere else and they don't access the services. The men's homelessness typically is associated with the loss of employment, retirement, mental health problems, addiction. We have our ideas of what homeless people are, why they become homeless. And so addiction is one of those. Loss of a job, retirement, loss of a spouse is a big one. Your sole source of income, and then your rent might go up and you can't afford to live there anymore. And on the other hand, women's homelessness typically is associated with trigger events. So we'll talk about what exactly a trigger event is. This usually happens for the first time in their life and results in homelessness. This could be financial hardships. Their husband dies, they can't afford to stay in the home they've had and don't have support services, don't have access to resources or benefits. They may be in an abusive or violent relationship and have nowhere else to go. Or they have been involved in unpaid care work. And thus they don't have the benefits, they don't have retirement, they don't have a pension. So when their husband does pass away, they have nothing to support themselves. Also, becoming a widow or having marital problems can lead to a woman becoming homeless as an older adult. And there's a big service gap between domestic and elder abuse services. So when a person does report elder abuse, there's really no services to support them or refer them to the necessary services. So if you're an older woman and you're in an abusive relationship, there's really not much more you can do in terms of support. And we're just finding out a lot of states and cities in the country don't have policies for shelters or homeless services to be prepared to serve older adults. So we're seeing, specifically in King County, we have like downtown emergency services, Chief Seattle Club. They're seeing more people who are becoming homeless as older adults or aging into homelessness, and they don't have anyone on staff that knows how to care for an older adult, what kind of access services for Medicaid, Medicare. They did change the policy a few years ago for the city of Seattle that if you are homeless and you're an older adult, you can be eligible to be placed in a nursing home. So a little bit about substance abuse, because this is what a lot of people associate with homelessness. And 49% of people who are homeless report substance abuse among those who are transitionally homeless. So they go in and out of shelters, they stay with friends. They're not permanently or chronically homeless. They kind of transition in and out. 66% of those are episodically homeless. Episodically means they're homeless for approximately 3 to 4 months, but they find shelter or a place to stay. And this goes back and forth over the year, but it's usually not longer than 3 months. And then 83% of those who suffer from substance abuse are chronically homeless. And these are people who are homeless without a shelter for longer than 3 months up to a year. And I'll talk a little bit about a study I've done, but I've worked with people who've been homeless 50 years. So alcohol is the most common substance. And drug use among homeless people is also rising, with heroin being the most common. And this is all ages, and alcohol is the predominant drug of choice among older adults. So trigger events are also referred to as transitions, such as becoming a widow, retiring, having a divorce. You lose your support of income that way. Domestic violence, you're evicted. We're also seeing a lot of older adults becoming homeless because their rent goes up 300%. And if you live on a fixed income of $800 a month and your rent's $2,500, you really can't afford to live there anymore. So where can you go if you don't have access to other support services? Declining health, so you can imagine if you have declining health, medical bills rise. A lot of the villages I work with in Alaska have this challenge of, do I pay my medical bills, do I pay my utility bills, do I pay rent, or do I pay for food to feed my family? So you can imagine if you're in an urban setting and the cost of living is just as high. Or the death of a family member. This is usually a spouse, or if you're living with other family members that are kind of a source of support for you. They pass away, that source of income disappears. This is not related to homelessness, but I'm learning that villages in Alaska are putting elders in nursing homes because the quality of care is better in urban settings. They can't really afford to keep them. Their chronic issues are too much to handle at home. But once they realize that support check went with the elder to the nursing home, a lot of families now are bringing them back because they need that money. So how does that work with housing also? So people who are over 50 who are homeless, as I mentioned earlier, exhibit health conditions and health problems with their physical and mental health that are common among people who are 70 and 75, who are the general population. So they are 4 times more likely to have 1 or more chronic illnesses compared to younger homeless adults. They have rates of chronic illnesses similar to the general population of those people who are 65, and these people can be 50. The literature shows that most people who do studies or work with the homeless older adult population choose 50 because they don't usually live long enough to reach later life. So we start with the younger population age. The percent of the population between ages 51 to 62 has increased from 18.9% to 25%. These are people who are homeless. So you can see it's rising. This is across the country. They're also referred to as an invisible population. Of course, we all see them. They're always there. When you think about service providers, healthcare providers, they're usually not people you would see in a clinic who show up for healthcare, who show up for dental services, who show up for mental health. They just don't seek out services. There's a lot of stigma around being homeless. There's a lot of uncomfortable feelings. People not really sure how to work with them, how to interact with them. And a lot of homeless people also fear shelters and soup kitchens for some reason. A lot of research hasn't gone into figuring out why that is. But we don't see many elders using services that younger people do. This also may reflect society's discomfort believing elders. These can be our grandparents, they can be your aunts, your uncles, your cousins, that they may suffer from mental illness or addiction, poverty, or you might find out they just don't have a home. And it's hard for us to imagine. I can't imagine if my grandma ended up homeless. I'm sure her family would take her in, but imagine if she had no support services. We don't like to imagine our own family homeless or addicted to substances. So homelessness has big impacts on health, mental health and physical health, socially, spiritually. If you think about holistic health, it impacts every person's activities of living. Increased physical frailty, so there's a lot of concerns about falls among older adults who are homeless. Chronic diseases are more prominent. Impaired mental function. And then they suffer from loneliness and isolation. Again, because they don't use services, they don't go to shelters, they become isolated and they don't interact with other people. So some chronic health conditions we see among a geriatric population who are homeless. A lot of them have cognitive decline. There's no studies out there yet that actually see what the prevalence of that is, or what is it? Is it alcohol-induced dementia? Is it vascular dementia? Is it some other form of cognitive impairment? But they exhibit memory loss, Alzheimer's disease, and dementia. They also have higher rates of falls. And vision and hearing impairment is big. And so having access to these services, knowing what is needed in each population will help improve their quality of life. So some of the behavioral health needs, we have people who've been chronically addicted to alcohol or substances their entire lives. So working with them and figuring out what's the best treatment plan. And helping people with mental illness address new ailments. So you can imagine if you're suffering from mental illness and you're homeless, you have chronic diseases, you might have addiction, you have insecurity, anxiety. So how do you create a treatment plan that addresses multiple comorbidities? And then health conditions, just across the board, are experienced across the life course, and they can be a risk factor for homelessness and put someone at risk or become an outcome of becoming homeless. The most common conditions we see in the population over 50, tuberculosis, HIV is on the rise among the homeless population, arthritis is really big, especially in terms of falls, hypertension, vision problems, hearing problems, like I mentioned, skin problems, so if you don't bathe regularly, you have skin issues, diabetes, fungal infections, parasites, and then traumatic brain injuries are also becoming more prominent. We're finding a lot of studies showing that traumatic brain injuries actually almost always leads to homelessness if they don't have an adequate support network. So getting that identified is really important, and finding the support to keep them off the streets. So what are some characteristics of homeless elders? This is in King County. 50% of the ER visits for the past 3 months have been people over 65 or 50, actually just 50. And then there are 2 or more visits for people who are 62 or older who are homeless. So the ER seems to be their prominent source of health care. 42% of hospitalizations are among people who are 50 and older. And then 2 or more visits were among 44% of people. 50% exhibit a chronic illness, 41% struggle with drugs or alcohol, and 33% struggle with mental health issues. So some service coordination needs. Everyone keeps asking, well, we know there's issues among this population. What can we do? Agencies want to know, healthcare providers want to know, social workers want to know, what can we do to help this population? People have talked about having home health care visitation, going to the shelters, providing services, occupational therapy, sometimes getting them back employed, giving them a transitional job, discharge planning. So if they are leaving a hospital and they're homeless, having a discharge plan, having social workers aware of what their needs are. And if they don't have a shelter, where can we send them? They'll continue getting health care. Medication management. So it's really difficult for people to go into an ER, get medication for something, and they have nowhere to go, and they don't have a follow-up visit scheduled. Ensuring that is in place, so you're not just sending people out with medications and no follow-up. Community building activities, I'll talk a little bit more about this in a study I've done. Having agencies that are serving homeless populations build a sense of community, get people involved, active in events. They've talked about having mobile doctor visits, so having doctors go around the shelters, the streets where people are most commonly found. And then having policies that permit stays in hospitals without losing housing. So if you're in transitional housing or temporary housing, you have to go to the hospital for something, not losing your spot because you had to leave, which tends to be the case if you're longer than 3 days. So other service priorities that are essential, medical and behavioral care and treatment. In fall prevention, a lot of falls, even among the non-homeless population, lead people to nursing homes and hospitals. So we're working with this population around that. High priorities are activities of daily living and instrumental activities of daily living. So keeping people functional, independent, helping them do basic chores, basic activities we all take for granted. We need to plan for more cognitive decline among this population. As we know, Alzheimer's and dementia-related dementias are increasing among all older adults, but we're seeing a rapid increase among homeless population. So how do we plan for that? What do we do? End-of-life care. No agencies are adequately prepared to have a homeless person in their shelter who passes away. Are staff prepared for that? Do they have palliative care nurses? Do they have social workers who can help? What's the process when someone passes away? And then emergency preparedness. Should an emergency happen, what do we do with this population? How do we help them be safe? And there's some that are medium priority that people are talking about. This ranges from nutrition and meal services, so ensuring they have an adequate diet, get nutrition. Issues of hoarding. I'm sure we've all seen that TV show Hoarders. So you can imagine if you have someone who hoards, helping them with that. Health technology. There have been some studies in Anchorage where they're using cell phones, giving cell phones to homeless people who have outreach. They can reconnect to family on Facebook and get reconnected and brought home. Or having it where they can access medical services. Effective targeting, homeless prevention. So being more specific about who we're targeting, what kind of services are needed. Figuring out how best to use our resources. And then transportation. In the study I did with homeless people, transportation was really key to feeling independent, regardless of whether or not they had a house. So keeping transportation available for this population is also important to their quality of life. Supportive housing works. There's that housing first model that I think some people know about, where people aren't required to be sober to get housing. And they're finding that even though they have housing, their drinking does reduce after 6 months. They're more likely to get a job, they're more likely to become stable. So getting cities more open to the idea of housing first models. So populations need integrated housing and services. This also includes strong case management, so social workers, healthcare providers, a medical team in place to address issues of isolation, helping people who may be afraid to leave their apartment because of stigma or other issues, fear of falling, mobility issues. And difficulty with accessibility. So you can imagine if you're homeless and you're in a wheelchair, accessibility can be really challenging, adding stigma to that. There's also a supportive housing shift. So we're looking more at a shift between what housing looks like, a line between housing and assisted living. So if you're in a shelter or a supportive home, what does that look like if you need to be moved to a nursing home or a skilled nursing facility? How does that transition work? We need to have our staff have new skills. So Chief Seattle Club, for example, we should have someone there who knows how to work with older adults, palliative care, end-of-life issues. How do you apply for benefits? A lot of the people who are homeless used to work, so they have access to Medicaid, Medicare, a pension, retirement. Keeping people in their homes as long as possible. If they have a home, if they have a shelter. Housing first, so looking at restrictions on how long they can stay, what's the requirements, keeping them sheltered, but also building more shelters. That seems to be a big push across cities all over. More homeless shelters for people so they can be home. They can be housed and get back on their feet. Linking services with medical respite, so looking at what those issues are. Improving Medicaid, Medicare financing of services. So this is a big, large government policy issue. If you're a homeless person, are you eligible for certain services? And if you're not, how can you change that policy to get access to this population? And then developing new partners. Homeless shelters seem to be isolated, they're very siloed. They serve certain people, but thinking about going across the board, how can Chief Seattle Club work with the school social work or a different agency, mental health, to collaborate with services and create an interdisciplinary team of people who can help this population. So based on surveys of homeless older adults, their needs are stable housing. Of course, they'd all like to have an income. They all want access to healthy foods, assistance applying for and accessing healthcare and social services. They would like specialized medical care that are not available in shelters. This is across the board with the population I work with. They'd all like to have access to specialized healthcare. Because your primary doctor only does certain things, but you might need a specialist. Then they were requesting training for medical staff to be more sensitive in working with homeless older adults. There's really no trainings on what you do when you interact with someone who's homeless or an older adult. The topic of aging in our society is very taboo. We don't talk about it. We want to reverse aging. We dye our hair. We get Botox. So you can imagine you have that stigma of being an older adult. When you add on being homeless, you haven't bathed, you might be addicted to substances. How do people adequately know how to work with this population in a clinical setting, in a shelter setting, or anywhere else where they might want to be interacting with people? So what are some of the knowledge gaps? So there has been some research. Most of it is coming out of Canada, surprisingly. Canada has very advanced policies for older adults who are homeless. But there's a lack of consensus regarding age at which homeless people reach later life. Is it 50? Should it be 45 if they only live to 60? How do we define this population to really give us parameters to work with in terms of developing the services, the programs, doing the research? We also need to better estimate the number of homeless people and their age distribution. A lot of the research out there is just guessing. You really have a convenient sample of people who are accessible to you, or you just come across when you're doing your research. But what are the real numbers? We don't know. So figuring that out. We also need to apply a life course perspective to understand what leads to homelessness. There really aren't a lot of studies out there that figure out what happened in your life that led to you becoming homeless, or have you aged into homelessness. So the people I work with that I've interviewed have been homeless 52 years. I've never asked her, well, what happened 52 years ago that led you to be where you are today? So we need more research there. We also need more research on the risk factors and those trigger events I talked about. So what are the risk factors? Can we help alleviate those or avoid them somehow when they're younger to prevent people becoming homeless as they grow older? And then we need greater attention to intersecting inequalities when exploring risk. So whether that's mental health, addiction, housing, widowhood, retirement. All these things play somehow into the lives of older adults. So looking at all of them and how they interact with each other. So what are the implications? We need to understand pathways in and out of homelessness so we can more effectively develop treatment plans. So if you have a better idea of the history of the person you're working with, you can better prepare to how to help them for the future. Our systems of care need to be improved to accommodate needs of homeless people. We need to focus on things that are modifiable, not things that are really impossible, especially if there's no housing available. We can't promise housing if there's none. But we can modify certain things like reducing drinking, encouraging them to reduce it. You don't have to actually promote abstinence, because that's sometimes impossible for a person who's been addicted for 40 years. But let's talk about reducing it, the strength-based perspective. Looking at common geriatric conditions, treating the skin issues, treating the fungus, treating things that can be alleviated in a short period of time and not making long-distance commitments that might not happen. So what does this all mean in terms of recommendations? What can we do? We need routine screening and counseling on alcohol use among this population. I also study alcohol among Alaska Natives, and this is a question that a lot of physicians don't want to even bring up with regular people. They don't want to get involved with someone's alcohol history. They don't want to be responsible if something happens. Same with Alzheimer's and dementia. They don't want to have that long conversation. They might not have the time to do it when they have office hours, or they don't have the adequate resources to offer them. So having that conversation, developing a screening tool to ask, how long have you been drinking? What are the struggles? We also need to address common risks for falls. This is one of the top reasons homeless people are in the ER or in a hospital, for falls or alcohol, or falls as a result of drinking. We also need to increase access to eyeglasses and hearing aids. Very simple things that would increase their quality, improve their quality of life. They can hear and see better. And then connecting patients with housing, or homeless people with housing. This would be adequate, of course, for everyone, but it's not possible. So how do we develop a system that gives fair access to everyone? So 3 models of care have been developed out of New York City that are now being applied across the country. Having a frontline geriatric nurse triage, so going around to different areas of the city. The second one is shelter-based convalescence or medical respite facilities. They're trying those out. Is that something that's going to work? Or do we need to change how we're doing things? And nursing care management utilizing a chronic disease self-management program. So teaching homeless people how to care for their own chronic diseases. These are kind of new still, so they haven't been really tested or researched to see if they've been effective and if they've been replicated yet. So hopefully in a few years we'll know more. Any questions about this large overview of homeless older adults before I move forward?
I was just going to ask, I seldom see a 70-year-old, somebody who looks that old. They're not making it that far?
So most people don't make it, if they're chronically homeless, don't make it that old, that long, they don't age that long. And also, there are a lot of older adults who are homeless don't go out in public. They isolate themselves somewhere. So you most likely won't see them out they don't know why they do that. But that's why a lot of the research and the programs are devoted to people 50 and older because they don't live to 70. So older adults are defined by a much younger age.
Are you aware of any data regarding rates of homelessness for geriatric patients outside of Seattle? Like in a rural area, for example?
I'm not sure about rural areas. If you Google homeless older adults, there's quite a few studies that have been done that are older, like 2004, 2005. Primarily comparing like New York City, LA, Seattle, San Francisco that do more of a larger picture. But I've never seen anything about rural homelessness anywhere, even internationally. Good question, though. Should be done. Any other questions? Okay. So I moved to Seattle 4 years ago, being someone who works with Alaska Natives. Strength-based perspective of my work, I know there's lots of problems facing Indian country. We have addiction, we have diabetes, we have chronic heart disease, we have everything. But I was really interested, and I still am interested in the strength-based perspective, so a positive look at what people do in Indian country, specifically Alaska Native communities. And being in Seattle, I was interested in urban aging, and then thought to myself, why wouldn't I access the homeless population? Let's work with them, see what's going on. It's a sore subject with my family. My cousin was homeless down here for 30 years. So every time I bring it up that I work with the Chief Seattle Club, I'm doing this study on homeless older adults, they shut down and don't talk about it. So that was mine, just to keep going. Like, oh, I'm going to show you. To do a good study and not highlight the negative things going on in this population. So I worked with a student who was getting her master's in social work, and we did interviews. And we targeted Alaska Native older adults who were 50 and older, because that's when they were younger. There was not many people that old except one person. We really wanted to know what is their skills, their talents, what are things that people never ask. We always make assumptions. I walk by homeless people, I'm guilty of it. I make assumptions about why they are there. They keep asking for money, they want me to buy their newspaper. These things that I see every day. But I wanted to expose people to a different side of homelessness. So I did a study on generativity, which is the 7th stage of human development, where we all go through the stage of generativity. We want to give back to preserving our identity and lead the future generations to lead better lives than we have. So I wanted to look at that. A lot of Alaska Natives I work with, this idea of generativity and teaching the future generations is key to healthy aging. So do the same ideas about healthy aging I've looked at fit with the homeless population. So we interviewed over 20 people. So I was very surprised. We had a budget for 20 interviews, but we had over 80 people who are Alaska Native older adults who are homeless wanting to do the study. So we know there's a population out there. And the population we had ranged from being homeless for just 3 months, so they're transitionally homeless, all the way up to 50 years. And this woman had talked about coming down here for a job when she was young. She didn't go to college, and she's still here. She hasn't had a home for 50 years. She lives on the streets. This is actually living on the streets, not transitional housing, not supportive housing. And so we administered 2 surveys 2 measurements to ask about optimism and generativity, and 80% of them, except one person, was very optimistic that tomorrow would be a better day, which was very surprising to me. I was not expecting that at all. And they all participated in activities that created a sense of community for them and kept them healthy in the way they knew how. For example, they created their own AA meetings. All the people I worked with are all sober, and they got sober on their own, and they found out that having an AA meeting led by themselves was more effective than going to treatment. They also engaged in prayer in church, so some of them went to church on Sundays, some of them went to pray by the water. They all played games. They all had their favorite games at the Chief Seattle Club. They all watched movies. One guy talked about repeatedly how he'd save up money and go to a movie theater once a month. That was his gift to himself by surviving on the streets. And everyone else talked about visiting with each other. They created a sense of community. They supported each other. For example, if a woman who was homeless had to go find a place to sleep on the street, because Chief Seattle Club's only open from 7 to 2, Monday to Friday. So all the people that are members there sleep on the streets or find housing outside in the evenings. So most of the people I interviewed sleep on the streets. So they protect each other. So if there's a woman they know from a village or a reservation community who's new, a group of people will go with her and protect her in the evening until she figures out who her group is. And then this idea of generativity, everyone I interviewed talked about helping someone else who is less fortunate themselves. They all talked about there's always someone worse off than me. Every other discussed helping someone else. So one guy said, I got $5, I bought a coffee and gave the rest to someone who was struggling worse than me. They buy coffee or lunch for others. So they'll give half their sandwich or buy 2 sandwiches. They'll get a couple pairs of socks. They'll give a pair of socks to someone else who doesn't have any. They teach others to survive. So the Chief Setup Club was really interested in bringing in outsiders to teach classes on how to get the members more involved, teach them how to survive, teach them all these skills to get them a job. When we realized, we found out through the study that all the members have skills they can do themselves. So why don't we have people who volunteer, who get services here, teach these classes? One guy said he has mastered panhandling. He can make $50 a day. He'd like to teach other people how to do the same thing. One woman used to teach college kids how to pass a GRE. So why can't you do that now? A lot of them talk about traditional cooking. They all said, I would love to do cooking classes. I'd like to teach people how to cook my way of cooking fried bread, cooking moose soup, whatever their favorite recipe was. So rather than bringing outsiders in from a different organization, now the Chief Setup Club realizes they have a wealth of resources here among the people who use services. Then they also talked about laughing was really important. Sense of humor about everything, despite how difficult their day was. They had to sleep on the streets, they didn't get any food. Laughing about things was really important. And then everyone who receives services at the Chief Setup Club also volunteers back at the Chief Setup Club, whether it's organizing the closet with the clothes donations, helping prepare breakfast or lunch, sweeping the floors, cleaning the bathrooms, volunteering in the game room. Everyone gives back. They're not forced to, they're not asked to, they just do it because they are thankful that someone has helped them when they were worse off, and now they want to give back to people who are struggling. So what is the overview of the study? We're going to build another study off of this because 20 people is very small, gave us a glimpse of what we're finding. But does this apply to other populations? Chief Setup Club also serves American Indians. So do the homeless older adults who are American Indian have the same views on life and optimism and generativity? In this study, which received a lot of publicity, which was really surprising to us also, we were interviewed by 4 newspapers across the state and in Alaska and DC. But we really highlighted the positive outlooks and skills of a population that's often forgotten. So looking at the skills and the talents of people that we just don't think about. And the elders who are homeless have a lifetime of skills and experiences, and they have this desire to pass it on to other people. So just because they're homeless doesn't mean they don't have this need to be generative and teach others. And then everyone sought out opportunities to teach others, show their skills and their talents. And now the Chief Setup Club wants to develop these classes that can be taught by members. And we can test whether that's actually effective. Are they enjoying this? Is it something they want to keep doing? So we're hoping to build on this study, do something larger, and figure out what's going on. Asking the life histories. If there's no studies out there that actually figure out why people become homeless, can we look at those risk factors and trigger events? Are they different for American Indians and Alaska Natives? So we'll see. Any questions about that study?
So has this study been done on non-Native Alaskan American Indians?
No. Not that I'm aware of. I've never seen one.
I was curious if there was a difference in what made them happy.
Yeah, I've never seen studies with other populations. These findings are identical to other healthy aging studies with other populations across the world. So there are similarities. Anyone else? So these are elders, so Nacogdoches is on the north side of the river, South Nacogdoches is on the south side of the river. South Nacogdoches has 16 people, and there's half of them right there. So they come over to Nacogdoches to go to the grocery store, get their mail. So they always want their picture taken, because if I become famous, they're famous. So that's the elders from South Nacogdoches.